So I'm just going to walk through this video just because there's a lot of steps and I'm combining almost everything. So I'm just going to go off our worksheet here that we had. So we have a 9-year-old patient, was in cardiac arrest. She was intubated. She's unresponsive with no pulmonary history. And so we are now setting up the ventilator. We already have everything set up here. When we actually grab the ventilator, everything is attached, like all of our tubing, our extra supplies that we have, and it's already been, one second, let me think of what it's already been calibrated. So we don't have to do that when we set it up. It's already completed and it saves us a lot of time. So we want volume control, no pulmonary history. So we're able to click this. Volume control. We're going to start at 100%, then we're going to wean tidal volume for this patient. She's about 5'5", 80 kilograms, and so we just want to set it about a 500 tidal volume. To adjust, I kind of just click it, turn it, and then I'm able to adjust. Eye time of a minute, or not a minute, 1 second, 12 respirations, slope of 2, PEEP of 5. Her blood pressure, we did check it and it was okay. Additional settings, our flow trigger is 2 liters per minute. So we are now ready to activate it. So we can just go ahead and press that. So now we are in volume control. As you can see, we have all of our things here. We have our current settings, and then this is currently the patient's minute ventilation, PIP, doesn't like that. It has all of our stats here. So we got the patient hooked up, and the doctor would first like us to administer a bronchodilator for some reason. So we do mesh nebs. They're a lot better than doing the inline aerosol or the inline nebulizer with the added flow, just because it'll mess up all of our volumes and make it inaccurate, and it's this is just a lot safer way to do this. So we have it in line with the inspiratory. I already have saline in there. So we would turn this to aerosol, and then we come over here and turn it on. As you can see, it is now nebulizing it, and every time an inspiration it gives a breath, you can see the delivery of the medication. There it goes. And so that is a way of delivering the aerosol without adding extra flow. So I can turn that off. I'll turn this back to, sorry. Okay, so, or instead of the aerosol, we can have an inline MDI. So we have this piece here. You would take the canister that you would have, and you don't want to put it in that device because it just connects right on here. You can pop that off and you place that on. So when you're holding it, you'll actually be dispersing the MDI. While you're doing that, you want to time it correctly that you're doing it with a delivered breath. So we can come over here and we can do a manual breath with a hold. So we are going to time it correctly so we can hold the breath while they're dispersing it and then release. And then if we want to deliver another one, we would time it right on with the hold, but it's a little hard to do with that. So they are getting that breath hold and they receive the medication. Make sure to pop that top back on. So we listen to the patient, sounding a little coarse, wheezy. The doctor physician recommends some inline suctioning. So we have our inline suctioning here. The technique is to push that in, but then we also want to make sure that we're not getting this all bunched up. We're not wanting to go like that. We are wanting to maneuver the thing in and then pulling the bag out. so that it's not all bunched up. So then when we suction, it's a lot easier. So once again, you want to do a good technique. And then we are able to have this hooked up to the suction, and we can, which we have about 15 seconds to suction. So it needs to be pretty, doesn't have to be incredibly quick, but it does seem like a lot of time. And then we're able to suction. I'm gonna turn off that alarm there. So that is inline suctioning, NDI and aerosol. So now we want to do some oral cares. We actually have our nurses do this, but we're also able to, I don't have any devices here, so I might just skip over that for now. So then we want to do cuff pressure monitoring. So we have this device here that we could use. I'm just going to include this. It attaches to your pilot balloon, and then we're just able to see that pressure. And then we are able to add the pressure. I'm just going to hold that there. If we needed to decrease pressure, we have this button here on the side. The only thing faulty with this is that by the time you pop this off, you're releasing that little bit of air there, so your pressures could be off. So our director or manager prefers just listening to it. So we would have this against the patient's airway, and we would listen. We could deflate the tube until we hear a leak, and then we know to add a little bit of air there so that we can correctly do that. It depends if the patient has a big or small ET tube. It could make it more difficult, easier. It mainly just depends, but they do prefer to do it this way instead of using the actual device. So then we have got it all set up. We did all that stuff. I checked the orders on here. So now it's time for documentation. So we do a flow sheet here. So it has we go to the patient's name, and then I already brought this up. So we have ventilator, and then we are able to first enter the ventilator settings. What mode are we in? What do we have all set? And then we're able to look at that over here and just put that information here. Here, the patient value. So this is when we do our vent checks, patient rounds, pretty much. We are able to look at the values here, clicked values, and all of this pops up of our current data, our tidal volume, PIP, compliance, FiO2. We're able to check that stuff. And then we want to enter, we have our minute ventilation over here. So we want to put all this information over here. So we have our tidal volume, minute ventilation, PIP, compliance, our SpO2. We have our FiO2 set up here. So we'd use an oxygen sensor, and we would read that off of our screen over there, and it tells us that, oh, SpO2 is 96%, and he's on 100% FiO2. We would want to start weaning. We want to wean the patient down so we prevent hypoxia. So we would just kind of look at those kind of things. Our alarms, what do we have our alarms set at? We can hit alarms, and it has our alarms right here. So we can just correlate to make sure, let's say this is the third day the patient's been on the ventilator, we're able to correlate to make sure that nothing has changed, or if it has changed, that we do document that. And then here we have our miscellaneous. Did we suction? Yes. Do we have our HME on? Which, yes, we do. Temp, when we have our humidifier, we can set our temp here. If I turn, I don't have it plugged in. So we have our temp that we want here, and then we could have a temperature probe to make sure that we're reaching that. And then of course we'd be able to go back and document any changes in breath or lung sounds. We want to monitor for adequate chest rise and fall with bilateral, they're both equal. Check for any sores that the patient might be getting around the face from the placement of the tubes. We want to make sure the vent is on the side of the patient, and so that it's not going across the patient or anything, so we're able to adjust that. And so that is all I have.